of this presentation is called CMR Rapid Protocol from research to practice. I don't have any disclosure. And this is a brief outline of my presentation today. In introduction, you can see here that the distribution of MRI units around the world. The general statement is that there should be around 10 to 15 machines per 1 million inhabitants. But the problem is that the distribution is unequal between developed countries and low middle income countries. You can see this graphic where you can compare the distribution of MRI units, and you can see, for example, in Japan, you can have even up to 55 units per million of inhabitants, whereas in other countries, such as India or Colombia, the distribution is even less for the amount of population that live there. And unfortunately, there are several countries, especially in low middle income countries in Latin America and in Africa and Asia that even do not report or don't have a statement about the current number of MRI units per million of inhabitants. There are several barriers that can affect the access of this technology in low middle income countries. Just some examples, for example, is first that the acquisition of the MRI machine by the hospital is usually costly equipment, and also once you establish the unit, you will have to use this machine for other organs, and the problem is that the cardiac scan usually is linked as a long scan and expensive and needs more training for doctors and radiographers, so that can also limit the interest of the management team to invest in this cardiac MRI hours allocated for that. The second one is a low health budget by governments. The problem is that, especially in low middle income countries, we have different healthcare systems. We divided healthcare systems where you can have the private with different rules, the public, the governmental, that is for mainly employees. There is another public that is the governmental, but is for poor economical resources people. Then we have the army, the navy, so it's different, the budget allocated but by each sector. Once we establish the cardiac MRI unit, there is the fact that there is an impact on patients' management, but the problem is if all these patients will access to the management that is suggested, for example, surgery or access to angiogram or medication. So that's another barrier that we need to consider. The education and training, and that is very limited, specifically in these countries. Most of the healthcare providers need to travel overseas for receiving a proper training. And the other thing is this service run by cardiologists or radiologists. Usually it can be both of them running the service, but there can be some limitations in defining who is leading the service. This is an alarming fact. You can see it's an old publication from 2011, but you can see here that the out of service equipment. So it's good to acquire the equipment, but what about the continuous service for keeping the machine up to date and running? So this study showed that in 16 low middle income countries, with the data analysis between 1986 and 2010, 112,040 pieces of equipment were out of service. So an average of 38.3% of machines were broken, were damaged, and that limited the continuity of a service. And this is a fact, especially in our countries. So we need to also tackle this issue. It's not only having the MRI machine, the people trained, also having the equipment running and have a proper service provided by the engineer and logistic team. Now let's focus about cardiac MRI. And the fact is that Cardiac MRI has a strong role in current international guidelines. This is an update from 2023, published in the JCMR, and makes an overall summary of the role of cardiac MRI unit and in the ESC, European Society of Cardiology guidelines, compared with 2015. And you can see that there has been an improvement in how these guidelines suggest the use of cardiac MRI. So 19 of 27 guidelines contain a specific recommendation for CMR. 40 are class 1 recommendation, 28 class 2A recommendation, and 19 class 2B recommendation. And there are 20 specific recommendations, and specifically for cardiomyopathies, 21 for stress perfusion. Those are the two main indications for this technology. Then other indications are vascular in 20 recommendations, 12 for general tissue characterization, 8 in cardiac function, 5 in pericardium, and 5 in myocarditis. So it's excellent to see this update document, and you can see how CMR is increasing its role and its recommendation in these guidelines, specifically remembering these two pathologies. And cardiac MRI have several applications. So you can see that, of course, we increase the number of sequences. It implies more training for you to run these sequences, but also assessing different parts of the heart. So we can assess the function of the heart, the left and right ventricular function. We can assess the presence of edema or inflammation, either with T2 stir sequence or mapping sequences. We can assess ischemia and first perfusion with first pass perfusion and assess ischemia, leg gadolinium enhancement to assess in scar fibrosis and microvascular obstruction, viability, flow assessment for the and we can see the valves, and if there is any stenosis or regurgitation, pericardial assessment. Also, this exam will allow us to see extracardiac anatomy, assessment of the pericardium, and constriction with tying sequences of real-time free breathing sequences, and finally 40 flow. That is one of the new technologies coming in CMR that is also helping to assess specifically vascular disease and also congenital conditions. So there are some considerations in cardiac MRI, and I want to put this as key facts that we need to remember. Usually we use cardiac MRI in 1.5 Tesla scanners in general, but you can see that there is a progressive inclusion of the 3 Tesla studies, especially for perfusion scans. So the magnetic field are usually between these two sites, 1.5 and 3 Tesla. No? One principal difference, and this is very important for you to remember, is the electrocardiogram, because you may be facing more difficulties with 3 Tesla and the ECG. And this is mainly related with the hydrodynamic effect that is more evident in the 3 Tesla scanner. You can see that there will be, and this is caused because of the blood flow that is coming from the left ventricle and going through the great vessel, the aorta, and this can have an impact on the on how the ECG is gated, and there can be a distortion of the image. Usually it starts with the changes of the ST and T wave sequences that can become more taller and wider, but then the highest effect, you can also see an alteration of the QRS. So this is something that is more noticeable in 3 Tesla, and you have to remember that due to the hydrodynamic effect. The second consideration with the magnetic field in 3 Tesla specifically is assessing this SNR, the signal to noise ratio. 3 Tesla can improve your signal to noise ratio, and this is actually more helpful if you want to assess pictures for stress perfusion, for LIGAT, and 3D whole heart. So there should be an advantage of this magnetic field of 3 Tesla for this for the assessment of specifically these pathologies. And that's what I said before, that usually we use 3 Tesla scanner for the assessment of perfusion, ischemia. You can see, for example, here the same patient and the comparison in the same with the same slices in the same slice position, and you can see that it's more clear to see the subendocardial defect in the stress perfusion in the 3 Tesla scanner, and this is correlated with the invasive angiogram. So this is an advantage of 3 Tesla, and we should also consider this key fact. The third fact is that CNS sequences, in this case, is a steady state free precession sequences. 3 Tesla can increase the sensibility and produce the commonly called banding artifact, banding and dark artifact. You can see here, for example, this artifact, and this is due to a flow artifact influence. And there is a fact that this is more common in 3 Tesla, but there is also some tricks, some changes that we can do if we are facing this problem. For example, adjusting our shimming and also using the frequency scout sequence that is available in the scanner and acquire the hertzius in accordance with this sequence is telling you, and following the acquisition of the scene images with the correct frequency in hertzius. So this can be improved. You can see it's possible to improve, but it's something that you should also face in the 3 Tesla scanners. So, and in general, remember that the magnetic field for cardiac MRI, we need at least an 8 coil in order to do cardiac MRI. This can allow thoracic coil. That this can allow us to see acquire parallel image acquisition, and also is capable to also help allow the patient to have to hold their breath. It's important to consider the correct hardware and software, and if we need to use ECG for that, electrocardiogram, and ideally if this ECG is also providing a vectogram, and then can help us to do prospective and retrospective ECG gating, which is very important if we want to, if we face patients with arrhythmia or breath holding problems, we can use this ECG and adapt the acquisition of the CNS sequences in accordance to the patient's ECG triggering. So you can see here the overall all the CMR standard sequences that we have in cardiac MRI. As a general statement, more sequences, more time, more complexity. And you can see here several sequences that we have in cardiac MRI. But the question is if we need to run all of them and when to run each sequence. And which of these sequences are important for clinical practice. So I will now go to the section of my presentation when I'm showing you the standard CMR protocols that we generally have in cardiac MRI. You can see here one of the most commonly used is the cardiomyopathies. The average time of scanning in general is around 50 minutes to 1 hour. And in general, this protocol needs to assess the function of the heart and also the assessment of the tissue characterization of evidence of scarring to assess the pattern of distribution and also the amount of scarring. For that, we need to use general sequences for all of our scanning. I will be showing this later in some videos. That is, for example, the localizers. Once we place our localizer that are our first survey pictures and start identifying and focusing the scanning into our heart, we will go to the CNS sequences. We will build up each of these CNS sequences based on the correct localizers that we do at the end, that is the 2-chamber localizer and 4-short axis. For a cardiomyopathy protocol, we can include mapping techniques, especially for specific cardiomyopathies that we will see later if we have the sequence available. We inject the contrast. We need to wait around 10 minutes is variable in accordance to the contrast agent that we have. But then we start acquiring the leg gadolinium sequences, and if we want to assess the extracellular volume with mapping technique, we also need to acquire the post-contrast T1 mapping. So in total, we are thinking about 15 minutes only for this protocol. If we want to assess, for example, the queries myocarditis, we need to also include sequences that can help us to assess the part of edema and inflammation. So to the protocol that I mentioned before, we also need to include the T2 mapping, and this T2 mapping or can be if we have the sequence available, or if you have a STER that is the most an older sequence, but is also validated to assess edema. We need to also include additional minutes for that. The same, once we do all these pre-contrast sequences with CMR and mapping, we go to inject the contrast. We need to have a waiting time, and then we go to the leg gadolinium sequences. So in total, we are talking about also a 50-minute sequence. If the query is, for example, assessment of arrhythmogenic ventricular cardiomyopathy, so we need, or any cardiomyopathy where is asking us to, where the doctor are asking us to do right ventricular function assessment or tissue characterization, we need to include also this additional sequence for the right ventricle. So we are also going to right ventricular CNA images acquisition that in overall, including the longitudinal and stack images, we will go around 8 minutes. If they are specifically asking about arrhythmogenic cardiomyopathy in the right ventricle, we may consider the use of fat suppression and saturation sequences that can be the turbospin echo T1. And we also need to acquire specific cuts. In general, are 4-chamber, 2-chamber, 3-chamber, and short axis, the same for T1 and T2 mapping. And then we need to do a waiting time as well after we inject the contrast and acquire our leg gadolinium pictures. So it can increase the time. It can go even going further. Here, for example, 53 minutes. But if the patient has an arrhythmia, is poor breath holder, is claustrophobic, so we may face a scan that is even more than 1 hour, and it can be more difficult for the patient to stay in that position for such a long time. So those are the general protocols that we need to face in most of our days working in the cardiac MRI unit. And this is a general statement for you to remember that. So why are we using this cardiac MRI technology in specific in cardiomyopathies? And the fact is that this technology not only help the assessment of the correct diagnosis of which cardiomyopathy we are facing, but also has an impact on prognosis and treatment. And the most common pathologies that have showed this important role of cardiac MRI within all this cardiomyopathy group is iron overload. So if we want to assess cardiac iron, because it not only help us to monitor the disease, but it also helps to direct the clinicians to adjust the dose of the medication to get rid of the iron in the heart, and this has a prognostic impact in patients' treatment, and that has been in patients' cardiovascular events, apologies, and this has been previously shown. So this is one of the pathologies where cardiac MRI has a complete role in diagnosis, prognosis, and treatment. The same is coming in other cardiomyopathies, and I want to highlight the role of cardiac amyloidosis because there are more evidence between 2022 and 2023 with clinical trials, not only for diagnosis, but only the impact of this, not only for diagnosis, but only for the impact in treatment and guiding the therapy, and also in prognosis with the support of the extracellular volume. And this is important because it's going towards the same direction as it went in the early 2000s with iron overload. Other pathologies that have a specific role as well is dilated cardiomyopathy, hypertrophic cardiomyopathy, I mentioned about the arrhythmogenic cardiomyopathy in the right ventricle and Fabry disease, where is one of the few conditions where you can see that the cardiac amyloidosis also has a role in early detection with the use of the mapping technique. So please remember that why we are doing this, why we are doing in cardiac MRI in this group of pathologies. And this has been recently updated with a new reclassification of how we focus cardiomyopathies in the ESC 2023 guidelines. So this is a key progress for the community, and I highly recommend you can also review this guideline as a general review and see how has increased the role of cardiomyopathies and cardiac MRI use, as I showed before. So please remember that from all the sequences that I have been discussing before, and to assess the diagnosis and follow-up, treatment, guiding therapy, and prognosis, there are essential sequences that are the most important we should consider. And those are the assessment of the function of the heart, specifically for most of the pathologies, the one that has more impact is the left ventricle assessment. Of course, there is also the role for right ventricle. Secondly is the tissue characterization that can be pre-contrast or can be post-contrast. In the pre-contrast, we can assess edema, diffuse fibrosis, and iron. And for that, we have all sequences and also mapping techniques. You have those available in your scanner. And for that, it will help us to assess, for example, edema with the STIR sequences, iron with T2 star sequence, and also diffuse fibrosis, in this case with mapping, T1 mapping. And finally, you also have the mapping sequence for T2 star and for T2 mapping that you can use as a plus if you have them available in your scanner. And finally, the post-contrast sequence that is mainly leg gadolinium enhancement to assess scarring and fibrosis. And as I mentioned before, this is a fact, and many units around the world are using mostly these sequences. This is the SCMR Global Registry, and you can see here published in 2017 by WON, and you can see here that the most common sequences using in the clinical practice worldwide is, of course, most of the countries participating here were high-income countries, were senior sequences with standard state fit precision, and also, for example, T2 weighting with the STIR sequences. You can also see that has been commonly used. And also the leg gadolinium enhancement in 73%. So these are the most common sequences that are available in the scanner. In all the scanners are more widely used. And from all the indications for cardiac MRI, the group that has more indication was the cardiomyopathy assessment of cardiac heart failure, that most of the groups are. Most of these cardiac heart failure are being aided by cardiomyopathies. That's the discussion for the next week, and the assessment of ischemia in 50%, which are the most high recommendations made by ESC in 2023. So remember, so the most common code for sent to the managers for the use of cardiac MRI is assessment of morphology and function with the use of contrast, with or without use of contrast. So regarding the volumetric assessment, remember that this needs to be done. The advantage of cardiac MRI, that is the gold standard to assess the function of the heart, left ventricle and right ventricle, is that it helps. The use of this volumetric assessment is done by a segmented analysis, so which prevents us to do a geometric assumption and have a more objective assessment of the overall global function of the heart. The disadvantage is we need to do the acquisition slice by slice. It will take more time to do the total acquisition. We need to have a correct planimetry of all the images. So considering the correct slide thickness, the gap distance, correct field of view, and of course, after the acquisition comes the post-processing analysis. You need a specific software for that, and it's more time consumption to complete the whole analysis. But in general, you can see, I would put, sorry about, in general, you can see that it's a better assessment because you have a 3D assessment of all these slices that reconstruct together and sum up the volumes of the endocardial and epicardial border in diastole and systole. And by a formula, you will have the correct assessment of the volumes of the heart and also the ejection fraction that can be indexed to the BSA of each patient. Here you can see the 2020 protocol acquisition recommendation given by the Society of Cardiomagnetic Resonance, and you can see which are the parameters that they advise for the correct acquisition of these pictures. For example, note that you have to have a correct temporal resolution, and even if you modify the field of view or increase or decrease the number of segments to gain more time in your scanning, that we will discuss later, you need to secure that your true temporal resolution is around 40 or less than 40 milliseconds. And for example, in general, they advise that the slide thickness should be 8 millimeters and the inter-slice gap should be around 2 millimeters. So that's how we usually do that. We need to check that this is correctly set up in our scanner. And in general, for the whole assessment of the function, you can see we go starting with the longitudinal axis. We can include the aortic valve, and the short axis comes after at the end, because we can plan based on our longitudinal axis acquisition. And this is again just a brief summary how you will do the post-processing analysis. I mentioned that it can be more tricky and lengthy. Post-processing usually done by the cardiologist, the radiologist, the medical team, and they will do these drawings of the borders of the heart and have a formula to assess the correct ejection fraction, both left ventricle and right ventricle. Regarding fibrosis, I want to highlight here that this should be done with leg gadolinium enhancement, that in general what it's doing is once it's injected, it will go from the blood pool side and go into the extracellular space. And if there is any major scarring or fibrotic myocardium, there will be a more distribution of the gadolinium in this area of scarring and fibrosis, and that will be what we will see in the pictures. And the thing is that we need to make sure that that we know the agent that we are using, the patient as well, because for example, the age of the patient, the distribution of fat can influence in how this medication is metabolized. Check the function of kidney function as well. That is a key important thing that we need to consider before giving gadolinium. And here you can have the current guidelines where you can see the distribution, how the leg gadolinium is distributed in different areas, and we can classify them in ischemic and non-ischemic cardiomyopathy. And key fact is that the leg gadolinium has a unique contribution in CMR because it has made a clinical difference in our clinical practice with assessment of fibrosis. That is something that we need to consider. For example, you can see here the distribution of if it's subendocardial or transmural in a specific area of the coronary artery. We may think that this is more related with a myocardial infarction. If it has a diffuse distribution, for example, is affecting all the walls in the left ventricle, in the right ventricle or atria, is more related with amyloidosis. If there is a pattern of scarring, is mainly in the apex, and the patient has a history of coming from Latin America and has an apical aneurysm. We can think in Chagas, the patchy scarring in the maximum wall thickness area in a patient with asymmetric hypertrophy can make us think about primary cardiomyopathy, hypertrophic cardiomyopathy. So it's important to recognize the pattern of distribution to make the correct classification of a cardiomyopathy. And this has been also validated by international guidelines about the role of cardiac MRI. You can see it's class 1 recommendation for the assessment and differentiate the type of cardiomyopathy. So late gadolinium enhancement usually is done by a segmented K-space acquisition. We have to do that in multiple planes and using the phasing sensitive inversion recovery sequence and also the magnitude reconstruction. Has different names for each scan, for each brand type of scan, if it's PLG, GE, or Siemens, and the usual sequence that we will include are the same as the cine sequences that we start, the longitudinal axis with 4, 3, 2 chamber, and the short axis. And here you can have an optional sequence that is a T1 Scout, also known as a locker sequence, where you can identify the correct inversion time, and you can define this time in milliseconds, and you can start applying the pictures based on the correct inversion time, where you can see the darkest point of the myocardium and the clear differentiation with the blood pool. Please be careful with late gadolinium enhancement. There are some facts that we need to highlight, and I want to do this very briefly. This is the European Radiology 2019 publication, where they make a statement about the use of contrast agents. It's a very important paper I think any radiographer should be reviewing, because in this registry they assess in total 72,839 patients, and you can see that they report that the acute adverse reactions in CMR were only found in 0.36% of this cohort of patients, and severe adverse reaction in even less, 0.033. So it's very, very unlikely we will have to face this reaction, especially allergic reactions. And the most frequent are more mild to moderate reactions, and they are more frequently reported with the stress perfusion CMR scans. And here you can see within the acute adverse reactions that are the allergic are more common than the physiologicals. You can see the different degrees of and severity of reaction. So physiologicals are very uncommon, divided in mild, moderate, and severe, including back pain, feeling sick, hot heating sensation, anxiety, etc., to the allergic reactions, which are more common which were more commonly reported, and it can be also divided in mild, moderate, or severe, and usually are related with hypersensitivity reaction to severe allergic reaction. Remember that there is a new statement of also from the European Registry, the EMA, the European Medicine Agency, and you can see that the contrasts are classified in high risk, medium, and low risk. And the high risk contrast agents have been taken from the market. We are talking about Optimal, Omniscan, and Magnevis, and then most of all centers around the world are going to the use of low risk contrast agents that we have here. Most commonly used is the Clariscan, Dotarem, or Cadovis. Here you have the classification and of the contrast agents, and you've probably had a previous talk about that, but they are based in the chemical structure and the charge of each of the gadolinium components that are attached to the chelator, and they are fixed and they can prevent any major complication. And we, as I mentioned before, we are going to those who have more stable structure, which have more cyclic structure, and also the ones that are more safer are the ionic compared with the non-ionics, like the Clariscan or Dotarem. And here, for example, the positive is that if you have a more stable agent, which is cyclic and ionic, as the case of the Dotarem or Clariscan, there has not been cases related with fibrosis, systemic nephrosis. That is one of the long-term complications that has been described before with the oldest agents, Magnevins, Optimal, Omniscan, that have been taken from the market. And the other thing is, please remember about the use of a cardiac MRI for the assessment of iron, specifically in this condition that is called thalassemia. Patients with thalassemia unfortunately have a condition that is multisystemic. It affects many organs, the brain, pituitary gland, there is iron deposition in the pituitary gland, there is problems with the growing and normal development, problems with the bones, also with the in the heart, with the position of cardiac iron. These patients have frequent hemolysis and they need transfusion dependent all their life. And unfortunately, one of the side effects of the transfusion is the iron deposition. So the thing is that this is, you can see here, for example, the position of iron in the heart, in the liver, and it's the same even color as the lung. And also you can see is probably at this stage you can see very dark heart as well. And these patients have to find other sources of red cells with extra medullary hematopoiesis. It can be in the ribs, in the sternum, or paravertebral hematopoiesis, but they have usually this mass of extramedullary hematopoiesis. And the thing is that we can assess the position of iron in the heart with a sequence called T2 star. It's an old sequence, is available in most of the scanners in different brands, but you can see that the problem is that the position of iron in the heart, it doesn't follow our rule. It's not that the liver comes first and then the heart, or the opposite. And the problem is that the most iron has the position in the heart, the highest will be the risk of mortality with heart failure or arrhythmias. You can see once the patient goes to more severe iron, that is when the T2 star is less than 20 milliseconds, and severe when it's less than 10 milliseconds, you can see that there is a higher mortality of patients. And when it's 6 milliseconds, you can see there is a 20% annual risk of heart failure. So the lowest this curve for T2 star goes towards 0 is the highest the mortality of the patient. And the role of T2 star, as I mentioned before, is that is also helping to change treatment, to help to change therapy, because we can follow up patients, we can see how they change their T2 star values, and that suggests the position of iron in the heart. And if they receive the proper treatment for the stage of iron deposition that they have in the heart and in the liver, and we do the follow-up and monitoring, we can get rid of this iron. It's difficult, takes years, because this iron is inside the heart, and it's a free iron, which is more toxic, but it's possible to do with the correct treatment. And this has an impact on patients' treatment, because as you can see, not in the UK, there has been a decrease of sudden cardiac death once they implemented to start as part of the treatment, as part of the diagnosis and monitoring treatment in patients in the UK. In 2000, you can see that the mortality of these patients with thalassemia dropped in up to 71% of patients. That's why I mentioned, remember, the risk is when the patients go with less than 20 milliseconds of T2 star, where you can report the most of the cardiac events of patients. And this is a study that I mentioned in the UK, published by Dr. Model, and you can see the drop of mortality when T2 star was implemented as part of the guiding treatment of patients with beta thalassemia in 2000. So the sequence that we need to use, remember that it is usually multi-echo gradient T2 star with 8 equally spaces that range from 8 to 18 milliseconds for the heart. And if it's the liver, usually is 10 gradient echo, starting between 0.8 to 1.3 milliseconds up to 12 milliseconds. It's more difficult to adjust the scanner for lower TE, but and the problem is that when the liver is more severe liver, there will be more inaccuracy in the assessment of this. There are other techniques to assess also iron in the liver, like the ferric scan. Remember that for the heart, you need to do a good shimming of the heart, and there are two options you can do. It depends if you have them available in your scanner, the dark blood and the bright blood. But dark blood is the preferred method used clinically, and it has a higher reproducibility and less artifacts. So you have the dark sequence, T2 star sequence for the heart, use the dark blood. And this is the method of analysis. It usually is only mainly done in the septum, in the mid-septum. So we ignore the other areas because they are more likely to have artifact. And so we need to draw an area of interest, a region of interest in the septum, and we will need a post-processing software. Some of them are free. The link is here, and you can also assess the correct value of milliseconds in T2 star and provide the severity of the iron in patients.
Take to improve CMR access worldwide, and especially in low-middle income countries, as this is part of the project that will be one of the parts of this talk, that is improving the access of cardiac MRI in low-middle income countries. So there were 3 principles for organizing this project. It was done with the support of my university, UCL, and Vars Health NHS. So networking and partnership with the collaboration institutions, in establishing an efficient cardiac MRI with using a abbreviated protocol, and the education that was delivered to the participant centers. So regarding the cardiac MRI protocol itself, there are some opportunities that we can take to make the scanning faster. One of them is leaving the sequence from the standard protocol, so using focus protocols. Second is scanning fast using accelerated clinical techniques that are available commercially in the scanner. Improving the workflow when the patient is scanned and during the changing between patients. And finally, the option of using smart technology, using automated image scanning, and also artificial intelligence. The focus of this project was mainly to tackle the 3 first difficulties. So leaving out some sequences and trying to focus on the essential was one of the most important principles for running rapid cardiac MRI. And as you can see from this number of sequences that we can run for a cardiomyopathy protocol that usually lasts 50 minutes, we can make it shorter, just focusing in the most essential. In this case, we may exclude the T1 mapping sequences and reduce the time to 37 minutes, acquiring the CNS sequences first and then having a waiting time to use the LMICs. And the question is, are mapping, specifically T1 mapping, an essential sequence in all cardiomyopathies? And the answer is no. There are just 2 specific pathologies where we shall emphasize the role of T1 mapping, and has been proven clinically, impacting not only the diagnosis but also in treatment of patients and outcomes. One of them is Fabry disease. You can see that Fabry is one of the unique pathologies within the spectrum of hypertrophy and cardiomyopathies that will bring the T1 mapping lower, the standard reference values. So it's a unique pathology where we can see this, and we can assess and differentiate from other pathologies. And in cardiac amyloidosis, where there are established guidelines by the European Society of Cardiology, where you can see that cardiac MRI has a specific role as a non-invasive technique that you can use, especially when this is keeping correlated with the clinical context and other imaging techniques like DPD scan. And you can see that the current recommendations of CMR in the assessment of cardiac amyloidosis are 3 things. Diffuse fibrosis, that is assessed, subendocardial fibrosis, going to transmural fibrosis, that is assessed by LMICs, abnormal gadolinium kinetics that can be seen with the T1 scout sequence, and the extracellular volume that is more than 40%. And for that, you need the sequence T1 pre-contrast and T1 mapping post-contrast. It's essential but non-diagnostic, but very supportive. And the most important role of ECV with most current publications this year is that it has an impact not only in assessing and differentiating this cardiac amyloidosis from other cardiomyopathies, but also in the follow-up of patients and outcomes, both for TTR and AL amyloidosis. So that's why we need to highlight the role of this T1 mapping in these 2 specific pathologies. But now let's exclude these 2 pathologies, and let's exclude mapping that also is not available in all the scanners around the world. So then another way to make cardiac MRI faster is acquiring the CNS sequences, the longitudinal first, and then putting the late contrast, and then do the short axis CNS after the gadolinium administration. That will give us a time for the wash in and wash out of the contrast, and then we can acquire our leg gadolinium pictures accordingly. And this has been studied before. You can see here this previous study by D'Angelo in 2017, where they compared if there was any difficulty or limitation in the assessment of cine function with the contrast injected before or after, and doing the acquisition before or after. And apologies. Yeah, and you can see that there was no difference. The endocardial definition was high enough after contrast administration that we can do a correct assessment of the volume, left ventricular volumes and mass. So this has been proven before, and we can do short axis acquisitions after the administration of contrast of the leg gadolinium. And the other faster way that can allow us to reduce from a time of 25 minutes to even less is just inject the contrast after the localizers and then do all the scenes. But we may have the risk of delaying the time of scene acquisition, and we can have the acquisition of the leg gadolinium too late, and that can be risky for the patient. But for the acquisition of the pictures and the image quality of the scan, but is another option we can consider. For the project that I will present today, we focus on this option, the 25 minutes protocol, where we focus on the assessment of scene sequences and leg gadolinium for the assessment of scarring, where we know that these two sequences have a role in the diagnosis and management and prognosis of cardiomyopathies. So now there are ways we can also limit the acquisition of the localizers, make it faster, as well as the scene sequences and the legat that I will be explaining now. For example, in the localizers, usually we do 3 orthogonal slices, axial, coronal, and sagittal. And the thing is that if the radiographer is well trained, we can do the isocentering only during the positioning of the bed, and then start doing the other sequences, so we don't need to repeat again. So it's very important for the radiographers to be familiar with the scanner and the isocenter correct positioning of the patient. Then we will go for an axial single shot fast spin echo gradient, fast spin echo or gradient echo in bright blood or dark blood to cover the entire heart and also cover the extracardiac anatomy. And then we will do the 2-chamber and short axis localizers that can allow us to see the scene sequences. I will explain that in a video later. And we can also reduce the timing of acquisition of our scene sequences. Usually, as a protocol, we have 4 to 3 chamber. You know, usually the protocol is already established in the scanner. You can adjust the thickness in accordance to what is recommended by guidelines. And usually acquiring these pictures in end of expiration and keep that consistent with all the acquisition of the pictures. Ways to make it faster, for example, is using partial Fourier, or for example, reducing the resolution of the phase encoding field of view. We can also reduce the resolution of the phase encoding direction, and also increasing the read out of the bandwidth, or if it's available, using parallel imaging. With these sequences, you can make your acquisition faster. And the same for legat. So these are examples how to do the correct planning of the scene sequences. But let me show you this video, and then we can be more familiar how to do this, the correct acquisition of pictures. So I'm trying to go from here, and as you can see here, so we isocenter the patient in the table in the correct positioning. If there is any problem, we can relocate or do the isocenter again with the command of the scanner when we are doing the scanning. After that, we are planning the second sequence. In this case, it can be haze or it can be bright blood spin echo, axial stack. We aim to cover all the thorax, and of course having the heart in the middle, and we are doing the shimming now, trying to put the heart in the middle and trying to avoid artifacts around them, and in all the positions in sagittal, coronal, and axial. So you can see it's 24 slices, slice thickness is 8 millimeters. You can adjust the distance factor in accordance to the size of the patient. This was a patient with liver iron and probably cardiac iron as well, so you can see how dark is the liver. So when we starting running this stack, axial Hayes stack, the next task of our scanning is with the two-chamber localizer. In this case, the radiographer is using the localizer as isocenter, and you can see in this view it's very easy to do the positioning, cutting through the apex and going to the middle of the mitral valve and the atria, and with that we are securing the two-chamber pilot localizer. This short axis localizer sequence as well needs to go in the atrioventricular junction groove, and we need to make sure that can be between 3 to 5 slices that can allow us to see both the left ventricular outflow tract, but also part of the basal ventricle. And here you can also see, based in the previous two-chamber localizer, that the radiographer is also trying to cut in the atrioventricular groove. And with that, we have the short axis localizer. Now the radiographer is again checking the correct shimming, going in isocenter to the heart. And with the two localizers, the two-chamber and the short axis localizer, 3 to 5 slices, they will start acquiring the short axis, the four-chamber sinus. In this case, you can see is going perpendicular to the two-chamber, cutting through the atria and the apex, and here ensuring that it's not touching the aortic valve, the LVOT, and going to the anterior superior border of the left ventricle and inferior border of the right ventricle, and that's the fourth chamber. For the two-chamber, just copy image position of your two-chamber localizer and trying to go perpendicular here, going in the anterior wall of the left ventricle and the inferior wall, trying to avoid the right ventricle. With that, also check this is right to left, so we need to have a proper field of view read to avoid any wrapping artifact. And this can be increased even to 460 or 400 to 450. No? That is for the two-chamber sinus sequences. So important as well to see the ECG. So you can see this patient is in regular rhythm. So for the acquisition of the pictures, it will go as a retrospective technique that is the most recommendable. But if the patient is arrhythmia, we can change in physio and go into other options like a prospective cine. So again, now you have to do the four-chamber sinus, so you are making sure that you are in the correct position and cutting also in half the left ventricle between the apex and the atria. And now finally the radiographer is doing the three-chamber cine, and for that you can see that it's cutting in the LVOT, the left ventricular outflow tract. You can see the aortic valve there, and it's cutting in the middle as well, and trying to go also through the middle of the apex as well, based on the four-chamber cine that they are acquired. You can see here in this view, localizer of the LVOT is also going through the middle of the aortic valve. The phase encodia direction for this three-chamber is anteroposterior, so that gives us a correct field of view of 360, correct ECG gating, and needs to be in this case retrospective, that we are capturing the whole cycle, all RR intervals, and with that we are doing three-chamber. And finally, she's focusing to do the short axis cine. So for the short axis cine, you can see we can have an orientation based in our localizer short axis and try to go covering correctly this area. And then we have the four-chamber, three-chamber, and two-chamber cine, and we will cover the whole ventricle, making sure that we are also covering the superior border of the bilateral wall of the right ventricle. We can increase the number of slices because this heart seems dilated. with some pericardial effusion. So we are increasing to 13 slices, distant factor 25%, a slide thickness 8 millimeters as recommended by the CMR guidelines, and we are reducing the number of concatenations. In that way, we will make sure that the patient can reduce the time of breath holding, especially if this patient is in regular rhythm and is a good breath holder. So we can reduce the number of concatenations, and we can do 2 acquisitions of CNET per 1 breath hold, and that can also help us to reduce the time by half. So this is just a general example how to start doing the CNET sequences for the longitudinal and the short axis, and then we can continue doing the protocol for doing maybe T2 star sequence or putting the contrast injection for doing the LMIC. Perfect. So coming back to the presentation, so I already explained how to acquire the 4-chamber, the 2-chamber, 3-chamber, and the short axis stacked. There are also ways how can we make the leg gadolinium acquisition faster, and it's the same principle as we do for the CNS, changing or reducing the field of view in the phase encoding direction, resolution, reduction of resolution, increasing of the readout bandwidth, applying parallel imaging or using partial Fourier techniques. And if we have patients with arrhythmia or poor breath holders, we can also use, instead of segmented leg gadolinium with magnitude and PSIR, we can do the inversion recovery, the single shot inversion recovery, where we can acquire the whole short axis stack in one single respiration and acquisition. But of course, there may be limitations in the image quality, but is good enough if we don't have any other option. And so in general, this was the protocol that we implemented in our study research in BARTS and UCL. You can see the acquisition of the longitudinal CNS. If there are options of mapping, you can include the mapping, and then put in the contrast and acquire the short axis and the LMIC. But if we have query for myocarditis or for pericarditis or ARVC, we need to include specific sequences that are specific needed for them, like for example RVC in stacks or T2 mapping if we are querying for myocarditis. So, and remember, there are patients that can have difficulties with the breath holding. So for that, you can do other techniques that I'm leaving in this table. So you can, as I was explaining before as well, we can do some changes in our scanning that can improve the image quality. But of course, we will have to pay something that is, for example, reducing the SNR, if we reduce the field of view. So there is a price that we need to pay that can help us to have a acquisition of the picture, but reduce the resolution, for example. And the same for patients with arrhythmia. No? If they are in fast atrial fibrillation, better to postpone the scan, give the patient correct medication, and bring them back. Using prospective gating as well, but we will have acquisition of less of the cardiac cycle, but at least we'll avoid the arrhythmia beating, or using real-time tuning as a last resource as well. And finally, I want to go through the workflow. So there are several options. For example, first, the radiographers need to be familiar with the scanner. And so correct position of the ECG. Here, for example, is you can see patient is already changed. The nurse already is greeting the patient and is bringing them inside the in the cardiac unit around the area of where we will put the cannula. The nurse is explaining with a lot of detail how to do the proper consent form, and also taking the observations, and also explaining about the breathing exercise. It's very important to fill in the correct safety form and check the patient is completely safe to do this scan, or if there is any contraindication to do this exam. During this, the cannula time, the radiographer or together with the nurse can explain about the breathing exercise, about the contrast agents, check that there is not any previous allergy or reaction to the contrast, explain that we will need to put ECG electrodes to trace the heart rate, and that can help them to have a correct acquisition of the pictures, the use of headphones, and the use of the emergency buzzer. And here is when the patient is already in the scanner, and you can see that in this case is GE, the position of the patient is different to Siemens or Philips. So make sure that there are at least 2 people that can be the doctor or radiographer and the nurse that can be together to work and support each other. Everyone needs to know their role, knowing how to correctly position in the ECG. Sometimes there can be 3 or 4 ECG leads, and then having a second person that can put the coil, the headphones and the emergency buzzer, and they can do the ISO center correctly. And for that, they must be familiar with the correct positioning of the table. Okay, so this is mainly about the workflow. Remember, the position of the ECG is different for GE and Philips, and there are several options where can you distribute, especially putting the ECG electrodes close to the bony area, and that can have a better signal. If there is a lot of hair, we will need to do some cleaning and shaving before that. Then remember, in our project that started in 2016 until 2022, there was the implementation of the rapid protocol, but there was also the education part to train radiographers and also the doctors to do the correct reporting. And as I mentioned, important the network and partnership. 5 countries support this project, and you can see the support in different levels: hospital, political level, scientific societies, the networking between my university and also the support of the CMR and the leaders of each participant center, which is very important. And you can see the results that in total we scanned 600 rapid scans in 11 centers, 7 cities, and 5 middle-income countries. The teaching that in total came as 5 international conferences with 920 attendees, and most of the pathologies that we assessed within cardiomyopathies were DCM and HCM. The most important message from this scanning from this slide is that the scanners that we used were old, so an average scanner age of 12 years. And in all the MRI brands, so especially because the sequence that we use are Cine and Leica that are available in most of the scanners. And you can see here the overall timing of the scanning for contrast cardiomyopathies was 22 minutes, and the assessment of iron, cardiac iron and liver iron with a non-contrast scan was 12 minutes. Good image quality, overall it was more than 82, 87% for good image quality, and also between good and moderate more than 90%. And you can see here that the overall impact, so we follow up this patient for a total of 36 months after we did the cardiac MRI scanning, and it has an impact in the diagnosis, changing diagnosis in new diagnosis in 22% of patients, and changing patients' care in overall 62% of participants. And here several examples of the use of this cardiac MRI unit to make a different diagnosis. And the overall impact also in saving. You can see here that in the 5 participant centers, before the intervention and after the intervention, based on the number of hours that they allocate for CMR per week and the number of scans that they do during these slots, there was a reduction, a potential reduction in cost between 30% to 60%. The positive is until now 82% of the participant centers continue practicing CMR. And this is an example of a second study that we did specifically in iron in India in 2 participant centers, not only doing the patient cam and scanning faster with a 10 minutes scan after the correct training and 1 year follow-up, but we also guided consultants, hematologists, and cardiologists to modify their treatment to patients with iron, and that helped to reduce a reduction of cardiac iron loading by 23% in 1 year. So we are also giving an impact in change of management in this population. And these guidelines have been currently adopted by, this protocol has been adopted by international guidelines, like the 2020 protocol acquisition statement. You can see the inclusion of rapid protocols with volumes and gaps, specifically for the segment of cardiomyopathy, diabetes, ischemic heart disease, and hypertensive cardiomyopathy. And in last year, CMR also published a statement about the use of a focused 30-minute CMR protocol that can be done for specific clinical indications, as you can see here, heart failure or cardiomyopathy. We will discuss that in the next week. Any substrate for ventricular arrhythmia, viability in scarring myocardium, or differentiating cardiomyopathy, ischemic cardiomyopathy and non-ischemic cardiomyopathy. And my final conclusions for this first presentation is that the access of CMR is increasing worldwide, but it still has an unequal distribution. As you saw in this presentation, we can improve the access of CMR in low-middle income countries by securing a partnership and collaboration with experts that can help support on the education, such as we are doing in this presentation today. Secondly, using a abbreviated CMR protocol, we went through from research to the clinical application of this protocol, specifically focusing in volume, gadolinium for the assessment of scarring or fibrosis, and T2 star for the assessment of iron. Overload in the heart, and in general assessing cardiomyopathies. We need the support of local champions and securing the stakeholders in each participant center. System is different, but we need to have them in our site. And the other thing that we would like to explore in the future is if we can also refocus CMR to our research, especially in low-middle income countries, especially facing pathologies where there is an epidemiological and also economical budget to be explored and studied. I just want to finish this presentation mentioning that every person is entitled to the same care, whether they are rich or poor. So we need to make sure that CMR can be accessible. And I appreciate all of you listening this talk, and you can try to also increase the access of CMR in your centers.